Hello, my name is Hunte-Lee. I'm an occupational therapist and occupational therapy doctoral candidate at Baylor University. Today we'll be discussing understanding OT's role in managing ICU delirium. So what is delirium? Delirium is a behavioral syndrome that is noted by a change in mental status exhibiting inattention, confusion, emotional disturbance, and other cognitive symptoms, such as decreased memory and decreased processing skills. This can take place over hours or days. Delirium is most commonly observed in the hospital setting and can be attributed to change in the routine for the patient as well as a change in their environment. It can occur as a result of certain disease processes as well as medications. Patient presentation. Patients may present with inattention or decreased orientation where they may not be able to remember things from earlier in the day or have trouble paying attention to what's happening around them. This can translate into problems remembering what the doctor said to them or if their family member came by to visit today. Decreased environmental awareness, they may not remember that they're actually in a hospital and they may try to get out of bed to use the kitchen or go to what they think is their bathroom at home. Cognitive and perceptual deficits, they may see things that are not there or may misjudge what they're seeing or how far it might be to get out of bed from the bed to the chair. Delusions, they may not recall things correctly that might have happened for them for the day. Emotional ability, they may have some moments of feeling emotional. There may be crying or inappropriate responses to things that happen to them throughout the day. They may become anxious or agitated, and generally they have some sleep-wake disturbances where they're unable to have adequate rest, and then they may be falling asleep during the day or up more at night, which is called sundowning. So there are different patterns to their sleep-wake cycle than they would have if they were at home. Associated behaviors with delirium include line pulling and aggression or agitation, where they may be aggressive with a caregiver or sometimes combative. They may use inappropriate words or have unintelligible speech. They may mumble or sound garbled. They may have decreased ability to follow commands or have difficulty understanding what they're being asked to do and have difficulty expressing themselves as well. They may also have abnormal movements where they may have some overall decreased coordination or they just may be flailing about a bit. So there are some variables with delirium. One would be level of severity. So are they a little bit confused or are they very, very unable to help participate in anything that you ask of them? It varies from time of day. Maybe they are very active at night and very drowsy during the day. They'll have different levels of arousal, and that can change from hour to hour, whether they're more active during one part of the day or more drowsy or have a better cognitive function during a certain time and then wax and wane, and then they won't be able to follow commands at another time. And just their overall symptoms of how they present will be varied between individuals. no two people are exactly the same, and even the one patient that you have can vary from day to day or hour to hour. So there are 3 subtypes of delirium. And the first one we're going to talk about is hyperactive delirium, where the person is just kind of constantly agitated and moving all the time. And that is actually the least common type of delirium. Even though you'd probably imagine that the patient's constantly pulling at lines. Hypoactive is when the person is very drowsy and very lethargic and difficult to arouse. And that accounts for the second most common type of delirium. But the most common is mixed, where the patient is at times hyperactive and at times hypoactive. So waxing and waning again, just depending on what time of day it is and how their system is reacting to the changes that they're experiencing. So just some things to think about from the patient perspective. The patient may feel like they're being detained. They're admitted and people are not letting them leave to go home. Why can't they leave? So because of their confusion, it can fuel some agitation for them. They may be experiencing a lack of control over their current situation. They may be depressed about their situation. Why can't they go home? When can they go home? Why is this happening to them? They may not remember what they were told about their diagnosis. So it's kind of an ongoing thing for them. They may be anxious, worrying about when they can leave, worrying about something that has nothing to do with why they're there. They may be worried about a pet. They may feel weak physically. So if you're in an ICU, it's very likely that you're not able to move well or be at your normal physical ability. So that again can fuel some depression and anxiety. They may have difficulty with memory. That includes short-term and long-term memory and working memory, and that can be a cause for frustration for the patient. They're most likely confused. Remember, not sure what time of day it is, how many days they've been there, when can they leave, and these kind of things kind of keep cycling and the patient keeps asking, but they're having trouble remembering. So just be patient with people because we as providers can't experience it for them, but we're there to support. One of the other things is nightmares. So sometimes patients do have those, and it's related to their sleep-wake cycle being poor and having night disturbances from possible anxiety and depression. In terms of medications, usually if a patient is starting to get agitated, it's related to their pain. So it's recommended that doctors prescribe analgesics first in order to do pain modulation in delirium patients. But if that doesn't work, they usually try light sedatives. If they are going to go for heavier sedation with dexmedetomidine, then that usually means that the patient is on a vent also. And for patients who are just very active and need to be able to relax so that they can rest a bit, it's recommended for them to try antipsychotics. Remember, sometimes patients are seeing things and very anxious, so if they try that type of drug class, it will help the person to be a little bit more calm and just be more tolerant of their surroundings. The one medication group that they do recommend avoiding for these patients is the benzodiazepines, because it tends to increase confusion and agitation. So if somebody's already agitated, you definitely want to avoid giving them something that's going to make them more agitated. So here are some common ICU delirium tools for providers. The most commonly used one is confusion assessment method for ICU, also known as the CAM-ICU. So that is administered pretty frequently by doctors and nurses, and can also be used by OTs or anyone. It is a way to determine if the patient can consistently follow commands. There's also the intensive care delirium screening checklist, which is also a checklist for how well the patient is responding to following commands. The Glasgow Coma Scale is a scale of alertness, whether the patient is able to do eye-opening, follow commands, and respond appropriately. The Richmond Agitation Sedation Scale is used in ICU to determine how agitated the person is versus how sedated they may be. And the goal for therapy is to have someone that's about a 0. You can probably work with somebody that's a -1, being hypo, but ideally you want them to be not agitated and also not sedated. For people with higher level cognitive abilities, you can try using the mini mental status exam or the St. Louis University mental status exam, SLUMS. And those are more to do with working memory and recall and calculations. But for folks who are vented, you would want to think more about a CAM-ICU, a GCS, or monitoring their RAS score. And the main ICU delirium tool for patients and families is the ICU diary. So being in ICU can be a very traumatic and confusing time for the patient. And for the most part, a lot of them don't remember any of that. And it is helpful for the family and the patient to process this difficult time by keeping a journal or a diary of what's happening. So people who are allowed or recommended to contribute to the ICU diary for the patient are the family, the friends, and the providers. And things that they can jot down in there are, I've watched you as a provider, I've watched you come so far, and I'm glad to see you're doing so well. Continue to improve. Or family members can send their well wishes in the book, and family usually they write down the events of the day. So, today patient had surgery on their elbow. They probably don't remember any of this at the time. Or today they had their first meal. They were allowed to have clear liquids, and they said that it tasted great, or whatever the patient might have said in response to getting something positive happen to them. Maybe there's something negative, a setback that they wanted to write down, but it just tracks the journey of the patient through their hospital stay. And then it helps them also with their recovery afterwards, so that they know what happened while they were really not able to remember things. OT interventions. So things that OTs can do, always remember to educate. Educate the staff, your nursing counterparts, family members, educate patients as appropriate. But in terms of the environment, always make sure that the lights are on and the windows are open during the day. Patients have a positive response to having an increased light in their environment. It helps them wake up and try to pay attention to their surroundings. Update the whiteboards. Sometimes the patient can actually see the whiteboard, and it helps them orient to date and time if they can see that today is Tuesday and it's October 1 and they can see it. There's also at night you want to do the opposite. Limit the light so that they can try to rest comfortably and improve sleep hygiene. If the patient sleeps well at night, then they can be awake during the day to do better participation in their ADLs and other functional activities. But if they're up all night trying to get out of the hospital or just being generally uncomfortable, then they're not going to be awake for you during the day. So it's just kind of, we need to get everyone on a daytime cycling schedule. So in terms of OT interventions for patient engagement, make sure that you are always trying to orient the person to their name, where they are, and the time. So the date, the day of the week, and the year. And also, if you can, ask them why are they here so that they know why they're at the hospital. Encourage them to communicate with the staff and family members if they're available. Have them sit in a chair if that's appropriate for the patient, if they can safely sit in the chair. If they're unable to, then put the head of the bed up as high as it can for them to safely be there. If you need to use chair and bed alarms, please do that. Safety first, but have them engage in whatever ADLs they're able to. So if that's oral care or combing their hair, if they're allowed to have a meal, then try to set them up so that they can do self-feeding. Just things like that to help them just engage in doing their own care and hopefully engage more with you and their environment. Encourage mobility as appropriate. So if the patient's able to walk to the bathroom, by all means, let's do therapy and get them out of bed and doing daily tasks. If the patient is overstimulated, it's okay for them to have what we call brain breaks. So essentially, you're going to make the room as quiet as possible, but the lights do need to stay on if it's daytime so that their reticular formation knows that it's daytime, and that they get used to being on a diurnal cycling schedule. So they're allowed to have quiet time, but it has to be that they take a nap in the chair and then you can re-engage. If you can get to them even a few minutes a day, multiple times a day, to make a consistent schedule, then that's considered a positive thing. These are references, and they're also included in your module for your readings. Thank you all for joining me. And I just wanted to reiterate, please educate other staff, especially like nursing. Please just educate them to maintain the things that you want for the patient to do during their day shift so that they're out of bed and active as much as possible. And that'll help with carryover for the patient and improve their potential outcomes. All right, thank you. If you have any questions, please don't hesitate to reach out.